Now, acute aortic syndromes are rare and very lethal, with around 3 incidents per 100,000 people. A very common acute aortic syndrome is thoracic aortic dissection, which is way more common in males than females. Incidents increase with age. The risk factors of an acute aortic syndrome are, first of all, genetic disorders such as the Marfan's syndrome, the Turner syndrome, and the Ehlers-Danlos syndrome. Other patients that are high risk for acute aortic syndromes are patients that have a family history of aortic dissections and acute aortic aneurysms. Of course, another risk factor is chronic hypertension, inflammatory vasculitis. Pregnancy in women is another risk factor. And the final risk factor is chronic exposure to corticosteroid and immunosuppressive drugs. You can see when it comes to the classification of an aortic dissection, there are two types of classification, the Stanford and the DeBakey type. Now, Stanford classifies aortic dissection into type A and type B. As we know, type A classification of Stanford involves the ascending aorta, and type B aortic dissections do not involve the ascending aorta. Now, the DeBakey classification actually further subdivides type A Stanford classification into type A1 and type A2, depending on whether the aortic arch is involved. For example, in type A1, based on the DeBakey, we have arch involvement, but in type A2, we don't have arch involvement. So the dissection stops in the arch. The aortic dissection is actually acute when we have less than 14 days since it occurred. What is the pathophysiology of aortic dissection? Aortic dissection is caused by initial tear in the tunica intima, so in the endothelium, which is of course associated with blood filling between the tunica intima and the tunica media. From that point onwards, blood may also leak in the adventitia, or even completely perforate the aorta and dissect into tissues. Now, all the signs, the symptoms, and the mortality associated with this disease depend on, first of all, the level of dissection and, of course, the branches that are involved. Now, 95% of patients with an acute aortic injury will complain from general pain. Actually, 3/4 of them will complain of chest pain, specifically chest pain that radiates to the intrascapular area of the back. Depending on the location of the dissection, it may also radiate into the abdomen. Patients describe this pain as sharp and tearing. This is exactly what happens because the aorta is being torn apart. In addition to that, 1 out of 6 people have neurologic symptoms, and a 10% will experience syncope, which means that they faint. Syncope is usually due to shock. Shock, as we know, may be cardiogenic. The causes of syncope may be myocardial ischemia or hemorrhagic shock. Clinical examination of a patient with aortic dissection, of course, involves the measurement of blood pressure in all 4 extremities. During the blood pressure measurement, of course, we check for the strength and, first of all, the presence of pulses. We have increased concern for thoracic aortic dissection if, when we measure the blood pressure on the upper extremities, because again we're talking about thoracic aortic dissection, have a difference in the blood pressure from the 2 arms, which is more than 20 millimeters of mercury. So if we measure the blood pressure in the 2 arms and we see a difference of more than 20 millimeters of mercury, we highly suspect a thoracic aortic dissection. Auscultation should also show a aortic insufficiency murmur. And in addition to that, aortic dissection may actually cause an ST segment elevation. An ST elevation, which usually indicates a myocardial infarction, could be caused by an aortic dissection. The chest X-ray scan should show, as you can see right here, a widened mediastinum, an abnormal aortic and cardiac contour, as well as the presence of tracheal deviation. In addition to that, we may also see a left pleural effusion. Of course, definite diagnosis is only done when we perform a thorax CT. As you can see right here, clearly shows the aorta and the true and false lumen. This right here is the false lumen. Now, for the treatment of an acute aortic dissection, the goal is, first of all, to keep the heart rate and the blood pressure as low as possible, of course assuring end organ perfusion. Αλλά φυσικά όλοι οι δρόμοι οδηγούν στη Ρώμη, μια επίγουσα μαχαιριά στο στέρνο να είναι η μόνη λύση. Αυτό ειδικά είναι type A aortic dissections, type B aortic dissections because they're for beta general surgeons. They can be also managed medically.